Thank you for the kind introduction, Mr. Chair, ladies and gentlemen. We move from injuries and nutrition, cold water, warm water, to another important aspect of aquatic athlete health, to breathing. In my talk today, I will give you some background information on asthma and introduce the study that we completed with our athletes in the aquatic sports, overviewing why we did it, how we did it, and of course, what we found. And we will close off with some recommendations with respect to athlete respiratory health in aquatics. So, to start off with, what is asthma? I think we all understand clinically that asthma is a constellation of symptoms that recur over time that are related to the respiratory tract. These are often variable from person to person, with the classic being wheezing and shortness of breath to someone who just has cough or difficulties in performance due to shortness of breath. Airway hyperresponsiveness is when the airways respond too much and too quickly or too easily to stimuli. And in contrast, the definition of exercise-induced bronchoconstriction is the acute narrowing of the airway in response to exercise. So there are many triggers to asthma, one of which is exercise, pollution, allergy, many different things that will cause this airway narrowing. So what is it in aquatic sports? What are we looking at? So exercise-induced bronchospasm itself may be variable. Different people have different amounts in the severity, and it can affect both performance as well as health. So it's an important thing for us to address because it not only affects our athletes' well-being, but how well they perform our sport. So how does it happen? In the literature, it can happen from high ventilation rates, breathing too quickly, from deep volumes, and I think I'm describing the type of breathing our aquatic athletes do. The airways can actually remodel or change the shape of it, the cellular structure caused by chronic inflammation and damage to the epithelium from these high ventilation rates and volumes. The aquatic environment that they are breathing may also cause damage to the airways, causing this reaction in the airways. It can be a sensitization to an allergy. And finally, we do note that airway remodeling, or that cellular change in the airway, occurs even without hyperresponsiveness in a healthy non-asthmatic swimmer. So there's something about swimming that causes changes to the airways. So let's talk about the study that we have conducted at FINA. This is a study looking at both how common is it and what are the characteristics of asthma in our aquatic disciplines. So the objective of this study was to see the prevalence in our aquatic sports in all disciplines, to compare the prevalence in different geographic regions of the world, to compare the prevalence of asthma in aquatics versus Olympic athletes that are non-aquatic athletes, and finally, to look at the prevalence of asthma in endurance disciplines versus the non-endurance disciplines. We used therapeutic use exemptions. So in anti-doping, as we all know, you have to receive permission to use a prohibited substance. And for the time period between 2004 and 2009, asthma medications, the inhaled beta-2 agonists, required a therapeutic use exemption with objective laboratory evidence of asthma. So as a result, we had data on how many swimmers, divers, synchronized swimmers had objective measures of asthma in the 2005, 7, and 9 World Championships, as well as the 2004 and 2008 Olympic Games. So this is a large quantity of athletes that we have. So in particular, we had almost 2,000 TUEs during this time period, the majority of them from FINA and a lesser amount from the International Olympic Committee. When we cleaned the data and looked at athletes that actually came to these events, we ended up with about 1,500 therapeutic use exemptions. This is a large study of objective evidence of asthma. And we had about 10,000 athletes during this time period. And if we look at our Olympic sports, we had 920 non-aquatic Olympic athletes with asthma and about almost 20,000 Olympic athletes in total. So a large study. To determine whether we had an athlete in an endurance versus in a non-endurance category, these athletes were separated not by arbitrary allocation, but by the WADA's evaluation through the distribution of whether they were classified as an endurance versus a non-endurance sport. So what did we find? Well, if we look at this graph, swimming, as you can see, is on your far left, and there are statistically significant greater prevalence of asthma in this population compared to, say, diving next to it, synchro, water polo, and even open water swimming. You can see obviously a blip in synchronized swimming and in open water swimming in 2008 in the Beijing Olympic Games. So you can see the results show a key finding that swimming has a higher prevalence than the other aquatic disciplines. And this is an important finding because it tells us that it's not only chlorine, it's not just the aquatic environment that affects the breathing. There's something different about swimmers compared to our other disciplines that causes the high rates of asthma that we see. When we looked at the geographical distribution, you can see very high rates in the North America, in Europe, and in Oceania in comparison to South America, Africa, and in Asia. There's this high prevalence. There must be different reasons for it, and we postulated this could be due to medical practice, this could be due to accessibility to the TUE system. Is there something genetic in the different populations? We don't know, but perhaps there are different reasons for this finding. When we compare with different Olympic sports, and I'm sorry it's maybe difficult to see, but you can see at the very top of your slide a low incidence of prevalence of asthma, and if we look at the bottom, there's a high prevalence of asthma. And you can see that the number one sport for asthma was triathlon, followed by swimming, open water swimming, cycling, and then synchronized swimming, modern pentathlon. Now the sports that had the lowest prevalence of asthma are weightlifting, taekwondo, archery, table tennis. So what's different about these two groups of sport? And I think it's very apparent that it's the endurance athletes that have higher prevalence and the more technical or non-endurance athletes have the lower prevalence. And if we compare these two groups, we look at the high bars are actually the aquatic endurance sport and the aquatic endurance and the Olympic endurance sports, and the lower bars are the non-endurance sports. So this clearly defines statistically significant difference between endurance athletes in both aquatic and non-Olympic disciplines versus the non-endurance sports in all of the events. So the endurance component of training actually is the distinguisher between asthma and non-asthma. So we look at whether or not there were anti-doping rule violations for athletes during this time period taking inhaled beta-2 agonists, because perhaps there were people that didn't have TUEs that had asthma, then I wasn't capturing their data in this study. And in fact, during all of this time period, there were only 4 anti-doping rule violations. So this clearly shows that their athletes were not being treated for asthma without having valid TUEs. So I think this is a very good confirmation that we were finding the right data. So some people argue that TUEs will have an underestimation of the prevalence of asthma because not all athletes will get a TUE, and that's a very real limitation of this study, that we only looked at TUEs. Other people argue that TUEs will give us an overestimation of asthma because people may get a TUE without having asthma. Well, during this time period, you had to have laboratory objective evidence to get your TUE, so I think that's probably not a valid argument. This study did not have any long-term follow-up. What happened to these athletes when they retired? Did these athletes have continual symptoms, or did they resolve to normal? And I think this is an important question that we must ask ourselves. Is this a problem that will give someone lifelong difficulties, or is this a time limited during their period as an athlete? And we also did not capture symptoms. We only had laboratory evidence. It was not possible retrospectively to capture symptoms. And is beta-2 agonists, are they performance enhancing? Well, we know that many of the athletes that won Olympic medals in 2000 and 2004 actually were having TUEs for asthma. And also in the 2008, we had significant number of people winning medals that had TUEs. But if we look at the literature, the inhaled beta-2 agonists as well as the corticosteroids show that it is absolutely not performance enhancing at therapeutic doses. So if the athlete is using it according to the prescription, there's no improvement to their performance. Some people argued whether or not the athletes were using this medication to give them a performance advantage, and at regular doses it does not. So why do our elite athletes win more medals? Maybe it's placebo, maybe it's training effect. I think it's time and training. So in conclusion, it's important from this study that team doctors, especially for swimming athletes, must learn to recognize asthma, how to diagnose it, and how to treat it. Because if you're an elite team physician for an elite swimmer, approximately 20% of your athletes will have asthma. There's more research required to determine the long-term health consequences, understand the natural history, and clarify the pathophysiology. And finally, FINA and organizing committees should be aware that 20% of athletes in the water here in Windsor will have asthma, and we should have rescue medication and education initiatives for our team doctors. Thank you for your attention.